and welcome. So, bonjour à tous et à toutes, et bienvenue. So before we start, I would just like to acknowledge that the Rotman Institute and Western University is located on the traditional land of the Anishinaabeg, Haudenosaunee, the Napewak, and the Adawarandun people. And we're very grateful to be able to occupy that land. The speaker today, so I'm very pleased to introduce the speaker today, Meredith Schwartz, who teaches at Ryerson University, and she does research in bioethics, broadly speaking, and she's especially interested in the ethics of pandemics, and this is partly what she's going to talk about today. But she also edited a volume with the title The Ethics of Pandemics that's been published recently, I think last summer. So it's an edited volume. And so the topic of the talk today is going to be, so I don't have the entire title in front of me, so maybe I'm going to let Meredith introduce her title. But so we're very happy to have you with us, Meredith. And so the way it's going to work here is so we're going to hear Meredith first giving her talk, and then we're going to have a question period that's going to follow, and I'm going to monitor the question period. So I'm going to give instructions for that as we get there. So I see that everybody seems to be muted. So thank you for doing so. Everybody's kind of used now to Zoom. I would like to remind everybody, if possible, to remain muted during the talk period. So, and then during the question, you can unmute yourself if you have a question. And I also would like to remind you that we're recording this talk. So yes, so enough instructions, enough. So I would just like to let Meredith give her talk. So welcome, Meredith, and the screen is yours
now. Thank you for having me. The title of my talk is It Takes Two, Trusting the Public in Public Health. Okay, so much of the existing literature in public health describes strategies that public health officials can use to build and maintain trust from the public. Typically, this relationship is assumed to be one-directional and instrumental. So that is, it's the public that is supposed to trust the public health officials. And the reason it's important to build the trust of the public is usually said that it will increase cooperation with public health suggestions. Now, in this paper, I want to think about the other direction of that relationship. So I want to argue that trust is actually a two-way relationship, and it's a mistake to expect the public to trust public health officials unless this is reciprocated. So I'm going to begin by describing a feminist relational account of respect as reciprocal, and I'm going to talk about it in the interpersonal situation briefly, and then move on to talk about the institutional situation and then public health in particular. And I'm going to consider the example of messaging around mask use that happened early in this pandemic, so between January and the end of March. And my abstract was very ambitious, so I said I was going to talk about 3 different examples, but it turns out that half an hour is quite short, and so I'm just going to confine myself to the example of advice around mask use. Before I begin, I want to say that I do not mean trust the public, as we've heard several senators in the United States or prime ministers or premiers in some of Canada, or as in Mike Pence articulated in the debate, where Pence said, the difference here is that President Trump and I trust the American people to make choices in the best interests of their health. This is a kind of laissez-faire type of trust, and it's not the kind of trust that I'm going to be describing, even though it might sound like it because he's also talking about trusting the public. I'm going to come back to this to explain why it's different from what I'm describing, but I just wanted to start by setting it aside because I thought it might be on people's mind when they hear about trusting the public these days. Okay, so I understand trust to be an effective attitude. So it's not something that you can just do at will. Um, Trust involves competence, a confidence in the competence, benevolence, and integrity of the person one is trusting. So we might trust the competence of the person sort of generally, if it's a two-place trust, like I trust you, but it might be domain specific. So we might trust the person's competence with respect to something in particular or with respect to some domain. So I trust you to do X or I trust you with Y. We also have to think that the person will act benevolently. So it's not enough that they are competent in some area, but we also think that they have to act in order to benefit us, not harm us. We also need to think that they're going to act with integrity. So someone could be both competent and benevolent, but lack integrity, and then we would not have reason to trust them. The last aspect of interpersonal trust, as I understand it, is that we have to have some kind of shared ends or shared values. So that is, we have to think that the person, when they're acting, is going to act in a way that is going to at least not violate our values or our ends. Now, trust is often open-ended. We often don't articulate everything that we want someone to do or what we're trusting them with. And for this reason, trust can be violated in many different ways. One way that trust can be violated is if the person takes on too much. So we might trust them with a secret. Maybe we're having a hard time in a certain way, and the person can violate our trust, not just by sharing that secret, but using that information to sort of act paternally and try to fix our situation. So trust is a little bit elusive. Nevertheless, well-placed trust is sort of foundational to human relationships. Things become a little bit more complicated when we're talking about institutional trust, because institutions lack the personal characteristics that we often rely on to decide whether to trust an individual. Nevertheless, I think that there are some shared uh, aspects between institutional trust and individual trust. First of all, institutions are made up of individuals. And these individuals sort of represent the abstract system of knowledge. As Anthony Giddens says, these are the access points to the different institutions. And so we might, for example, trust medicine because we trust our doctor and because we've had good experiences with doctors and nurses and because we see the doctors and nurses as trustworthy, that might sort of spread to the institution of medicine as a whole. In contrast, if we have bad experiences with access points, this can undermine our trust not only in the individuals involved, but also with the entire institution. So, for example, if you're an Indigenous person and you've experienced repeated racism from your nurses as they're treating you, as happened in Joliet, Quebec, you might figure that nurses are not trustworthy, even though the rest of Canadian society tends to think of nurses as trustworthy. You, as an individual, might think that all nurses are not trustworthy. And this can spread to distrust in the institution as well. So, having bad experiences with the people who represent the institution can undermine your trust in the institution as a whole. For example, I'm on a Facebook group called Urban Indigenous Canada, and they were having a discussion around the Canadian government's recent announcement that First Nations reserves were going to be given priority in access to the vaccine. And many people there did not think this was a good thing. They thought it it was them being used as guinea pigs. And they were saying things like, oh, are these vaccines going to come with blankets? What about body bags? Referring, of course, to the smallpox and the H1N1 near pandemic, where the government sent body bags to the reserves to deal with the possible consequences. So In those cases, their past experience undermined their trust in the institution of public health and vaccination. So, in the case of institutions, it's not so much that they have benevolence, which is a personal characteristic. Instead, it's that we might think that the institution is set up in order to benefit us, that the aims of the institutions or the ends of the institutions are things that are going to be good for us. And of course, whether this is true is going to depend on our social location. So, most institutions have arisen to meet the needs of particular social groups. And so they usually benefit those social groups, but differently situated social groups might not benefit from those same institutions. So, one, of course, that's been in the news quite a lot lately is the institution of policing. So, many people from wealthy white neighborhoods see the police as benevolent and their presence as a benefit to them, as a protection. Whereas people in racialized neighborhoods and indigenous people often see the police presence as a threat rather than as a benefit. So we have to see the institution as sharing our ends. So the kinds of things that we trust when we trust institutions are unspecific because different people within the institution will have different roles in order to meet those ends. So we don't trust them with one specific thing. We might, for example, trust public health to promote the health of our community, but epidemiologists, public health nurses, public health physicians, infectious disease control specialists, all of these different people are going to have different roles. And it's also an impersonal kind of trust because institutions don't have personal characteristics. So, what about public health? I think public health has an obligation to be trustworthy, particularly because, well, I've already mentioned the instrumental reasons, but particularly because public health has broad powers to limit individual liberties in order to protect the public health, as we've seen in this pandemic. In the case of public health, it can be a little bit difficult to determine whether we have shared ends, and these can actually come apart. So, Nuala Kenny, Françoise Baylis, and Susan Sherwin, in their relational account of public health ethics, say that one of the values that underlies public health ethics is a relational sense of solidarity, where we all have a shared interest in safety, survival, and security. But as we've seen in this pandemic, sometimes those actually come apart. So, public health issued slowdown orders to try to slow the spread of the disease by closing various things to various degrees. And so, this is protecting our interests in survival, but it might not protect our interests in security and safety. So, for example, for people who are experiencing violence at home, it might increase our decrease our safety as it puts us more in contact with the person who is committing violence against us. For people who are small business owners or who work for the kinds of jobs where you can't do them from home, such as waitresses or hairdressers, the need to promote our survival, to lower our chances of getting this illness, might disrupt our security. So our sense of being able to continue on our day to day. Another thing that is complicated in the public health situation is that while there are people who represent public health, like doctors Anthony Fauci and Theresa Tam, and we might trust these people because we believe that they're competent experts in their field who are looking out for our interests, it can be sometimes unclear exactly who we're trusting. And this is because public health officials offer advice, but it's government officials who make decisions about how public health is going to address these issues. So, are we going to have lockdowns? Are we going to lock down certain things and not others? How are we going to ensure safety when we do open things back up? Those are all government decisions, not public health decisions. Nevertheless, I think that government actions can sort of spread to the public health agents themselves. For example, in Ontario, Doug Ford offered us advice against gathering for Mother's Day and then saw his own daughters. He told us not to go to our cottages and then went himself. And I think for many people, Doug Ford's actions caused them to lose trust in public health advice, even though it wasn't public health agents who were doing those things. So in public health, there's a real tangle among who it is that we're trusting and what it is that we're trusting them to do. But I think public health does have an obligation to be trustworthy. So now let's turn to the example of masks and mask wearing and whether we should wear masks. It's important to note that in North America, it's a bit more difficult to get people to wear masks. So in North America, we sort of associate masks with some kind of oppression or some kind of removal of our rights. And so in order to get people to participate in mask wearing, there's sort of an extra hurdle as compared to Asian countries, perhaps. So this image from The Handmaid's Tale sort of shows that just covering someone's face is a way of representing that they're being dominated and controlled. In fact, I got this image from an anti-mask website that was using it to illustrate how far the government has gone to limit our liberties. But it doesn't have to be that way, because in North America, we're also very used to covering our faces in winter. So I think that there is the opportunity to make our messaging around mask wearing and mask use something that is comforting rather than controlling. But that, of course, is going to require trusting in the public. So I thought I would begin by just asking you to reflect on what you remember about advice around mask use from January to late March. And maybe if people could just take a minute and write it in the comments, because I'm actually interested in this question. And so it's a good opportunity for me to get some feedback, which I'm not going to look at now, but I will look at that at the end. So if you were to say, what was public health telling us from January to late March, the message changed in April 3rd in the United States and April 6th in Canada. That's when they began to say it's okay to wear masks. But from January to late March, what do you remember about the messaging? Okay. So I'm not sure if people have the same reactions as the other people that I've surveyed, but when I've done informal surveys asking people about how they remember the messaging around mask use, what I hear most commonly is that people remember that they told us not to wear a mask. And I went back and reviewed the information, and they were saying that the public shouldn't use the mask, but it was a little bit more of a subtle message. So public health officials were saying always first that we should save the masks for healthcare professionals because they're the ones who really need them. But then they would go on to say, and this was consistent from the World Health Organization to Dr. Theresa Tam to Dr. Anthony Fauci, all of them were giving this message. They would say, there's no evidence that masks work for the general public. And there might be negative effects from the public using masks. So they would say, masks don't protect your eyes, and so this might give you a false sense of security, and so you might be less likely to do the physical distancing measures. They would say that if you're wearing a mask, you're more likely to touch your face, and so you might be adjusting the mask, and you might be more likely to touch your face. And they also said, if you don't remove the mask correctly, you can actually increase your chance of self-infection because you might touch the mask as you're taking it off, fail to clean your hands, and then wipe your hands on your face. And then they also say, we're looking into it. So we're studying it more. We're doing further research. So we'll keep you updated on the information. Now, I want to look at this message in terms of trust. especially thinking about the competence, benevolence, integrity, and shared ends aspects of trust. So I think that this is not a very good public health message. It is truthful, however. So it's not that they were lying to us. Um, at the time, there were studies that looked at mask use, particularly around the control of influenza. And these studies tended to find that masks didn't work when they were used by the general public. However, the question that was being asked in these studies was, does mask use protect the wearer from getting influenza? And they found, well, it didn't really, for the reasons that are mentioned, the negatives there. So they weren't lying to us exactly. I did find some studies from 2006 that looked at source control, but these were usually by Asian authors in Asian contexts and might not have been widely read. So they were being published in Asian journals. So, what about the negatives here? All of these negatives suggest to me that public health doesn't think that people are competent to wear masks properly. However, the negatives can also be compensated for through public health messaging. So rather than saying masks don't work, in fact, they're harmful, they could have said, save the masks for healthcare professionals. We're going to spend this time educating you about how to properly use masks. And this is entirely a possible thing to do. I worked at Sick Kids Hospital during the first SARS near pandemic in 2002, 2003. And as soon as we had SARS cases in the hospital, we got educated about how to wear masks properly and how to don and doff them properly and how to dispose of them properly. So rather than just stating the negatives, which assumes that people won't be competent to do it, they could assume that people will be competent if they're supported with the tools and knowledge around how to do this correctly. Um, the other thing that I'm concerned about is, did they know that masks work? To me, it was very jarring because it seemed very contradictory to say that it's extremely important that healthcare professionals get masks, but they don't work for the public. So, how can that be true? If they work for healthcare professionals, then they could work for the public once we are made competent to use them correctly. So I worry that they added these extra negatives as a way of being misleading to the public because they didn't trust that the public would act beneficently and with integrity in order to preserve the supply for healthcare workers. Now, obviously, if public health had said masks do work, but we're going to educate you about how to use them first, that does open up the opportunity for people to be malevolent, right? So it does open up the opportunity for people to act in a way where they would hoard masks and make them unavailable for healthcare professionals. However, precisely what it would mean to trust the public is to trust that the public is going to share in the ends of preventing the spread by staying home until we have enough masks. And we could have done lots of things like shared mask patterns, shared information about how to correctly use masks, and then said our supplies are okay and we can begin to buy masks if we need to. Okay. At the time, there was also evidence that masks work based on correlation. So if you look at the countries where the pandemic got under control, such as Japan, Singapore, and Hong Kong, there was widespread mask usage. And by the beginning of March, end of February, public health officials from China, South Korea, Singapore, Taiwan were already being interviewed in the newspaper, pleading with public health officials in Europe and North America to begin to recommend mask usage. So I do think that there was already some evidence, perhaps not perfect evidence, but perhaps enough evidence that we should have been thinking about having a precautionary principle in use. So, what about the fear that the public would panic, that recommending mask use right away would cause people to go out and panic buy? After all, isn't that what we were seeing with the disappearance of toilet paper and flour and things of that nature? Um, I think that there isn't actually good evidence for this. So, the social science literature that looks at human behavior and behavioral psychology literature has actually begun to abandon the idea of panic in the times of disaster. And this is because in times of disaster, what you really do see more than panic is people banding together and becoming even more altruistic. And so rather than focusing on preventing panic, the behavioral science and social sciences are now focusing on how we can capitalize on that altruistic response that people often have. And I would suggest that actually trusting the public can be one way to increase the likelihood that people will respond altruistically. And there is some evidence from this in the behavioral sciences. So, in behavioral science, they have developed what's called a trust game. And in this game, you have two players, and they have the opportunity to start with $10, and they can share it or not share it, and they can choose how much they want to share. But whatever they share will get tripled, and so then they'll both split that. And then the second player has an opportunity to share or not share. And then again, whatever they share is tripled. And what the behavioral sciences have found is that people do tend to be generous, and people reciprocate that generosity. So most people choose to share at least something, and most people reciprocate as well. And they've also found that the likelihood of reciprocating increases the more risk the initial player takes. So if the initial player only gives one or only gives two, the chances of reciprocating are not as good. Whereas if the initial player gives three, then the chances of reciprocating are very high, and the chances that they will reciprocate with three are very high. Um, so, in the case of preventing panic, one way that we might be able to elicit the altruistic responses from the society would be to trust them and give them accurate information, and to say that we want you to save it for the healthcare professionals. The reason I think that this might trigger an altruistic response is that it's actually a fairly big risk. So, by being honest, by saying, they will work, but we have to educate you on how to use masks properly, um, the public health officials are taking a risk. They're taking a risk that people will behave maliciously. And I think that might, I mean, this is an empirical question that needs testing, but I think that might lead to a more likelihood of altruistic behavior. Okay, so um, I think after that discussion of mask wearing and the messaging around mask wearing, I can begin to flesh out what I think it means for public health to trust the public. First, I don't think it would be appropriate for public health to already trust in the competence of the public. Instead, I think the role of public health is to build and support that competence. Um, and the reason for this is that the kinds of things that public health asks us to do are difficult, and they are not things that are well within human nature. We're social animals, and so we like to be around others. And so asking us to stay home is actually quite difficult. Also, the issues involved in pandemic responses are complicated, and most people aren't epidemiologists, and most people don't have degree in infection control. And so rather than trusting that we're already competent, they should help to build that competence. Um, and so this can involve education, but it might also involve sort of more material ways of building that competence, such as what we saw with the SERP, the kinds of material things that you need to participate in the recommendations of public health. I think that they do have to see the public as benevolent, even though obviously not everyone within the public is benevolent. But I think that if we want to help elicit the altruistic behaviors, it helps if our messaging conveys an idea that the public is benevolent. Again, this will be an impersonal and unspecific kind of trust because there's no one in particular that you're trusting. It's the public at large. And you might be trusting them with a great number of things, not something in specific. One of the things that I think makes this different from other kinds of trust is that it lacks reactive attitudes. So often when we're talking about interpersonal trust, we think that a betrayal of trust, it's not just a disappointment, you somehow feel wronged. And I don't think that it would be appropriate for public health to react to public failures with kind of scolding or with anger or with a sense of betrayal. But I think this might actually be something that is characteristic of any asymmetrical relationship and not specific to public health alone. So, for example, I think that in the doctor-patient relationship, patients need to be able to trust their doctors, and doctors need to be able to trust their patients. For example, doctors trust their patients to tell them the truth about their lifestyles and their symptoms. They trust them to take the advice of the doctor, and they trust them to contact trace in the case of sexual health diseases, for example, where the person says that they want to do the contacting of their sexual partners themselves. So in these cases, though, between a doctor and a patient, it doesn't seem like it would be appropriate for the doctor to engage in reactive attitudes with the patient who fails to do so. And that might be because of the power imbalance between doctors and patients, where patients are relatively powerless to towards their healthcare professional. And I think the same thing could be said in public health. So it doesn't make sense for public health to react with a sense of betrayal or anger if people fail to follow public health directives, in part because they have such power. So I tend to think that asking the public to do something first is better, but if the public fails to do that thing, then mandates become appropriate. I think mandates should be a second step rather than a first, because mandates tend to get pushback. So people, when they're being mandated to do something, that's when they begin to feel like their freedoms are infringed. In contrast, voluntary measures, if they're followed, have much less pushback. But public health always has that in the background, right? They always have the capacity to recommend that governments institute mandates of various kinds. And it's because of that imbalance in power that I think reactive attitudes are not appropriate in the case of public health trusting the public, whereas they might be appropriate in the case of the public trusting public health if they feel that their trust has been violated. Okay, now just to come to this quote from the debate, I'll tell you why I don't think that this particular kind of trust is the kind of trust that I am talking about. So Mike Pence and various others offered similar sentiments. Pence says, the difference here is President Trump and I trust the American people to make the choices in the best interests of their health. And this is from minute 26:55 of the debate. The reason that I don't think this kind of laissez-faire trust is the kind of trust that I have been describing is that it assumes the competence of the American people without actually developing or supporting that competence. And because I'm offering a relational account of public health, I think that you need to think about how differently situated social groups need to be supported in different ways. And I think that in respect to mask wearing, Toronto at least could have done a better job of that. So some places were handing out free masks, but then they stopped doing that. And so when I've seen people who have less money, you can tell that they've been reusing their masks over and over again. So I think we could have done a better job of getting masks to people in an ongoing kind of way. But in the case of President Trump and Pence, there was a lack of support given to the American people to allow them to comply. And there was also a lack of leadership and honest discussion. Okay, so I'm at the end of my time. In the standard discussions of trust and public health ethics, the public is expected to trust public health officials. So in the model that I've envisioned, trust is built among agents. So when public health officials trust the public, this helps to build trust in public health officials. Suggesting that public health officials trust the public involves some differences from the standard case of interpersonal trust. In particular, in cases like a pandemic, the public will mostly have limited competence as we lack knowledge about unfolding events, and the behaviors we are asked to participate in are difficult for social creatures such as ourselves. One role of public health is to help build the capacities among the publics to enable us to act in a trustworthy manner. Other elements of the standard count are present. For example, in trusting the public, officials should demonstrate confidence in the public to have shared ends and to behave in ways that promote the public good. In short, I think that trust is like the tango. It takes two. Thank you.
Thank you very much, Meredith. So now we are going to pass to the question period. So to do so, you have two options, but here's my favorite option, is that you actually use the blue hand function that you can find by opening the participant tab. So at the very bottom of your screen, if you move your mouse, you should see a participant tab. And then if you open that, then you should have a raise hand function there that you're going to see. And the other option would be to use the chat. So I'm going to try to monitor the chat as well. No promise that I'm going to do that as well as looking at the blue hand. So if you have any questions now for Meredith, just you can raise your hand or use the chat. So I have a question. I think I've seen Carolyn first. So Carolyn, you can go ahead and ask your question.
Thanks so much, Meredith, for coming and giving the talk. We did a seminar and a reading group about trust this fall, so it was really helpful for you to know that at the end of that, you were going to be coming and giving the talk. I just wanted to suggest some stuff from recent work on trust and philosophy that might support some of the work that you're doing, particularly when you're talking about how trusting the public might sort of encourage them to be more altruistic or trigger a kind of altruistic response. So there's recent work by Tori McGeer and Philip Pettit on trust, where they develop what they call an empowering theory of trust. I think supports that idea. So the idea is that when you trust someone, you're almost sort of providing, well, you're giving reasons for yourself to be trusting, because your trust itself will empower them to some extent, in most cases, not all, to actually do what you're trusting them to do. So they appeal to literature on human psychology to make that point. So I wanted to suggest that. Also, with respect to the trust theory that you use about what trust is, right, in the talk. I mean, I like that theory. It resembles my own a lot, but I also worry that it might be too complex, or more complex than you might need. And I think a more probably the most common view of trust now in the philosophy literature is what people call a trust responsiveness view. So when we're trusting others, what we ultimately expect from them is competence, but also just a kind of responsiveness to our trust. I mean, this requires that they're actually aware of it. But people like Karen Jones now and others think that that's ultimately, that's all we need for trust, really, is this expectation of a kind of responsiveness to our trust. So the public might trust in public health, so members of the public might trust in that institution if they get a sense from the institution that it recognizes how much they're depending on, the public is depending on them. And so it recognizes that the public is already trusting them in a sense, and it's showing a kind of responsiveness to that. On these accounts, that would be them, showing this kind of responsiveness to that dependence is enough to engender trust, if that makes sense. So that's a much weaker theory, or more minimal theory than one that lists the many criteria that you've got. Yeah.
Right. Okay. Well, thanks for that. My view of trust is very inspired by yours, in fact. So that might be why it seems similar. In the trust responsiveness account, can that apply to institutions? Like, can institutions respond to trust? Or that, I think, is...
Yeah, I think it's a good question. And that kind of theory has never been developed. I mean, very few trust theories very little has been written really on institutional trust. But you can imagine an institution kind of conveying somehow to the public that, we recognize that you're relying on us, that you're really dependent on us, and we're taking that responsibility very seriously. I mean, that kind of messaging would fit with this sort of trust responsiveness account and gendering trust.
Okay. I guess that is okay, but one of the things that I'm not sure in the trust responsiveness account is whether things like the differences between social groups. So I think different social groups might see these institutions quite differently. And that doesn't seem to be merely like they're responding to the trust, but also that they have to be sort of beneficial to the person in a certain way, rather than oppressive to the person. Well, anyway, I'll look at it in more detail and think about whether it could apply to institutions.
I think that's a good point. Yeah.
Thank you, Carolyn. So the next person I've seen raising their hand is Chris Mick.
Hi, thanks, Meredith, for a really interesting talk. So I have a question that's about, it's more of a policy-oriented question. So are there things that we can learn about how to enhance trust in public institutions from places that have done it well? So there's a really striking empirical contrast between how South Asian countries have fared in mask use versus North America and Europe. And there's all kinds of confounding factors here. So it's just a common cultural practice already to wear masks, and that might be more important than any question of trust. But if you look at other cases of public health, are there cases where, and this is not really the main theme of your talk, but are there cases where you can say, here's a context where the people did trust in their public health policy guidelines and it was effective, and can you draw any sort of conclusions from that about how to do better? I mean, the US has been particularly horrific, but are there cases that we can look to as aspirational guidelines?
Yeah, sure. I think, so I'll just go outside of the Asian context because of the cultural tendency to wear masks there. So it might be less difficult to get people to participate in that. But I think that some of the places that you could look at where people did seem to have high levels of trust in their public health officials would be places like New Zealand, where they moved quickly, decisively. They had the goal of eradication, which is the goal that actually, I think, benefits the population the most. So in Canada, we didn't have the goal of eradication. We had the goal of preserving hospital capacity, right? Which kind of benefits people, but not as much as eliminating the disease from the population. Now, of course, New Zealand has a lot of differences, namely it's an island, right? And so it can shut its borders more easily than we can. but it also had high levels of participation in those guidelines. So people were willing to shut down. I believe that they also gave them a fairly long, they said 28 days. We're going to shut down for 28 days. And so that was a fairly long period of time compared to North America, where we were saying 2 weeks, we're going to shut down for 2 weeks, but then it just got extended into another 2 weeks and another 2 weeks and another 2 weeks until eventually, at least in Ontario, they were like, okay, it's going to be a month or whatever, at least. So I think it might actually be useful to give a longer time frame and then potentially be able to dial it back rather than constantly trying to extend the time frame, because that I think makes people feel greater level of uncertainty.
In terms of your analysis, does that allow for the public to sort of build competence and then sort of feel more in control of their own, sort of managing their situation? So it's actually in some ways a more aggressive goal, that you're sort of giving the public more information up front, and so is that the key, that they're sort of building competence in the people?
Yeah, it's the building competence. So I think it makes them more psychologically able to participate in the recommendations. If it's sort of put out in a robust, this is really serious, you have to do this, then you can dial it back. But it's hard to start from a dialed back recommendation and keep increasing it because you don't feel like you know how to plan, right? Whereas if you say, okay, we're going to do 2 months shutdown, oh, okay, then that's what I have to plan for. But if it turns out to only be 1 month, well, oh, that's great, Another thing that I think is interesting about the New Zealand case, and I didn't get into it in my presentation, although I do get into it in the longer paper, is that New Zealand's pandemic preparedness had a social justice focus right from the beginning. So if you read the paper by Nuala Kenny, Françoise Baylis, and Susan Sherwin, A Relational Approach to Public Health Ethics, there they actually hold up the New Zealand pandemic preparedness plan as a model of one that builds in these considerations of inequalities. So I didn't mention this in the presentation, but the mandate to wear a mask, of course, has different effects on different populations. Not only those who have medical reasons not to wear masks, but some sexual assault survivors say that having anything over their mouth can be very triggering. And we've heard from the United States that some African-American men feel that wearing a mask puts their lives at risk from the police, who will see them as more threatening. So I think having a pandemic preparedness response that is attentive to the way that these policies can have different effects on different groups helps to build trust, because it makes it seem like the policy shares ends with all the different groups rather than being made for the elites, as I think the North American response is sometimes seen, right? It's a thing for the elites because only the elites can stay home and work from home, and those essential workers have to go and deal with the public. So those are things that I think can build trust.
Great. Thank you.
Thank you, Chris. So next we have Jenny.
Thank you. I really enjoyed that talk. Thank you for letting me come to this. It's one of the nice things about the pandemic, that you can come to talks in places where you aren't. I was really, I can see why you want to distinguish what you're saying from what Mike Pence was saying. I mean, we always would want to distinguish whatever we're doing from anything Mike Pence does. I love your selection of the photo of him, by the way. But I was thinking there might be a more direct way of distinguishing what you're saying from Mike Pence, which is that I think he's totally insincere.
Yeah.
I mean, I'm not somebody who knows the trust literature, but I mean, if you just actually don't care what people do, then saying that you trust them to do the right thing just seems insincere. It's not real trust. It's just a way of avoiding responsibility. So I was wondering if that might be a useful way of dealing with Mike Pence's claim of trust.
Sure, I guess so. I was trying to avoid imputing too many motives to people. So when I was talking about the mask messaging, I was trying to just look at what they said and not try to read too much into what they meant, other than to say that I think that the save it for the healthcare workers was really what they meant.
Mhm.
And for Mike Pence, I am not sure that he's sincere, but I'm also not sure that he's not sincere. So, but I think that if you look at what they did, then you can see that there was a lack of support for the competence skills that people would need to comply with the public health advice, right? So there was a lack of modeling mask wearing, for example, to help normalize it. There was a lack of material support given to people who were maybe hadn't lost their jobs, but were experiencing much lower tips because nobody's going to restaurants and that kind of thing. So they did give, EI benefits, but if you didn't completely lose your job, there was not as much support. So I can say that with certainty, whereas I can't really say with,
I can
with
see
certainty
that.
whether he was sincere.
And that last point about uncertainty, I think that was something pretty obvious from the beginning, that we were, it was really unclear how to interpret many of the things that were said, because many of them were contradictory and they kept changing their mind. So how can you even trust in the first place what they're going to say you if it looks like they don't even know what they're doing? Like the unpreparedness for something like that was blind. So that's all played in the background. So yeah. So we have still time for questions. I don't know if other people would like to comment or ask questions to Meredith.
Well, it's interesting to me that in the chat, most of you did take away the message that they don't work and they're not necessary, because that's my experience from people I've talked to in general. Is the main message was negative, even though there was always this kind of actually more nuanced message, right? We need to save them for the healthcare workers, and there's all these problems when people try to wear them. So my suspicion there seems confirmed, which is one of the reasons that I think that offering a more positive message would be useful here, because people really did take away that negative message. And so it's not surprising that there's anti-maskers now.
Yeah, and unfortunately, when this movement gets going, then it's hard really to stop it. Yeah. Okay. Well, if there are no other questions for Meredith, we'd like to thank you for this wonderful talk. Thanks everybody for their questions as well, and for coming. I hope that everybody's going to have a wonderful break. Break is coming. I know there's a bit of grading before, but the break is there. And thanks everyone. Take care. Stay safe. Wear your mask.
Bye. Thanks for having me.
Yeah, you're welcome.